or she will. All right, Amber, take it away.
Sorry, I'm still on my phone. I'm having a hard time reading our agenda here. So we can go ahead and call our meeting to order. We are going to hopefully finish up the rest of these drug profiles today. I think we made quite a bit of headway on the last meeting, which was great. So if we can kind of maybe scroll through what we did the last time, Shelley, maybe, and just kind of reorient ourselves to where we left off and what we still need to finish.
Okay. Got the first one pulled up is sodium nitrite.
Yeah, do you have the list we edited, Shelley, also? Because we had some suggested deletions from the table 5.1 or whatever it is.
Oh, I think I put that in the draft minute.
Oh, did you? Okay.
Attendees also discussed updating table 2 to remove drugs already listed on table 1 and remove drugs activated charcoal, pyridoxine, and sterile water.
Yeah. So Dr. O'Connor, we were just discussing removing those couple of things, the activated charcoal. It's not in any of our state T3Gs to use it, or, and I don't know that many of the agencies are even carrying it. So we suggested removing that one. And then we had a line in the drug table for sterile water. So we took that one out as well.
Was the sterile water just for like irrigation if somebody got, or what was the like?
No, it's just for mixing stuff. It was just if you mixed stuff with sterile water. So it was just like a diluent. It wasn't even something we would use.
Yeah, no objections to taking those off.
And then I guess you can go back, Shelley, to the PowerPoint then. Do we have to approve the meeting minutes? We don't have to approve those, do we, for this work group?
No, just let me know if I got anything wrong.
And I don't know, you guys tell me how you want to do this. Do you want me to just jump in with a couple suggestions I had when I looked through this? Or do you present it in a different fashion?
Yeah, that's fine. We can kind of go through these if you want to, kind of one by one, and we could address the highlighted portions of it. I don't know that we had any that were unfinished, right?
Yeah, I just would, for sodium nitrite, I always, you're exactly right with the highlighted portion. It's hypoxia and hypotension. I would consider contraindications, and the issue, and actually for the indications, I thought with, it says can be used for hydrogen sulfide poisoning. I would actually say it's rarely indicated, because really in the field, right, the key is getting people out of the environment and away from the exposure. And often they will, if it's not been a severe or life-threatening one, they would quickly recover. If it has been severe or life-threatening, making a call of giving someone sodium nitrite is tough, because I've seen it precipitate a code because they just can't tolerate for their hypoxia. They can't tolerate the hypotension. So I would actually say rarely indicated more than.
Maybe just remove it then, the line entirely. If the perceived risk outweighs, the rare benefit, maybe we just remove that as an indication.
I'll defer to those who know what the EMS providers are taught more than I do. I know that hydrogen sulfide, there's anecdotal human evidence without great randomized controlled trials, no really great data. And I think I've seen it cause more harm than good when used inappropriately. So however we want to do that, whether you want to leave it as a mention or whether you want to take it out completely, I'll defer to those who know how the medics are trained as far as making that call in the field.
I think Tanner's on the line is kind of a field perspective. Thoughts on that, Tanner? Not to call you out, but
I was gonna say, oh, great, fantastic. Yeah, so it's taught in HLS as being the antidote for hydrogen sulfide poisoning. I think in the paramedic tox world, that's why we carry that drug. We carry it less and less for the cyanide poisoning because of the introduction of the cyano kit. So.
Okay, then I would say keep it if that's really the only reason that we're keeping it for.
So I have a question. If you look at the guideline for sulfide poisoning, before initiating treatment, the EMCT is directed to consider consulting with the regional poison center. So based on that, what is our sense of what direction they would get if they called a regional poison center from the field? Would they just be getting blanket advice not to administer this agent then? Because if so, then that would certainly compel us to reconsider this whole guideline.
So from our standpoint, from the poison center, Banner Poison Center, the issue would be, removal from the source of exposure and a high flow oxygen would be the first two steps of that treatment algorithm. And then the third, I can't remember the times that I've seen this used, it did not go very well in an actual hydrogen sulfide suspected exposure. Because a lot of times you don't have confirmation in the field that that's what it is. And sometimes it's simple hypoxia. And if you give this drug to a hypoxic patient, you can precipitate a rapid code. So you wouldn't get that. You wouldn't get a recommendation to provide this through our poison center, I wouldn't imagine. I mean, I guess it always depends on what toxicologist might be on, but universally we know that hypoxia and hypotension are contraindications to this drug. And its benefit outside of removal from the source and oxygen seem controversial, or at least not well substantiated by evidence. So, but I do know that's what people are taught, and that is a consideration or a thought behind it. So I would just, if we're going to leave it in, I would just say it's rarely indicated and perhaps under the guidance of the Poison Control Center. That might be a way to circumvent the whole thing.
Yeah, I know that, I mean, for a long time, because of the expense of the cyano kits, we had sort of left, at least with our tox medic courses that we taught in our regional group, we kind of had left the sodium nitrite and the thiosulfate on as a recommendation, mostly because there were some departments that couldn't afford the cyano kits or enough of the cyano kits to cover them for cyanide toxicity. And so it had kind of been left on because of that, but I don't know that it is used very often for the hydrogen sulfide poisoning. And so I guess I just question whether or not we keep it or consider eliminating the hydrogen sulfide, at least the order. I don't know. I guess I'm kind of on the fence between, my concern is if it's not used very carefully, that the risk of harm is greatly outweighs any potential benefits to the rare patient that it sounds like it could be beneficial in. It sounds like the potential for harm is way greater, and in my mind, a reason not to use it at all for that indication.
Erin, how often it's Shari, how often are they hypotensive and hypoxic? Like if you say every case that we've seen, or like predominantly, they're always, they're going to present this way to begin with. So it's a non-starter that it's rare that we would even consider using it, because every presentation we've seen of it is already hypotensive and hypoxic, would go even more towards taking it off.
Yeah, I mean, typically when you have a patient found down after a gaseous, suspected knockdown agent, hydrogen sulfides to mind, but a lot of times it's simple asphyxiants that are present: methane, propane, butane, and or carbon monoxide and or dioxide. They're often mixed exposures, and those patients often, to your point, are hypotensive and or hypoxic. So it's not necessarily something we would use. It's typically something we would have historically used just for cyanide exposures in the absence of hydroxycobalamin. Yeah, I mean, you could either remove the indication as far as using it for hydrogen sulfide, or you could just make the caveat that in rare circumstances it's potential treatment, but it often practically cannot be utilized in these patients. So,
Gail, would it be out of context for today's meeting to consider this discussion insofar as what it means for the actual treatment guideline today?
No, I mean, I think as we get ready to restart the TTTG update for 2022, we could certainly, look at updating that. I think, the drug profiles will go to PMD in November and then MDC in January, final approval. But I think we just update this based on what we think is, best practice for a paramedic that's utilizing this to learn from. So most likely they're going to be using this when they're doing their initial training or some type of refresher. And so with that knowledge, what do we think would be the most beneficial way to word this?
Dr. O'Connor, how often do you see either confirmed or suspected hydrogen sulfide toxicity in terms of poison center volume or number of cases per year?
Exceedingly rare, and often it is actual patients. It's usually not real-time confirmation, right? Like it's usually working with the folks on the scene who go in and do scene assessment and figure out what gases were present. But no, very, very rarely. But I think it depends on where they are, right? Like if, places that pig farms or places that have big manure pits, industry settings in which we know hydrogen sulfide exposures occur are out there. So folks making calls to those specific locales that have a known hydrogen sulfide use in their occupational setting would be.
Maybe we say that it's rarely indicated except in certain cases, certain industrial locations or certain industrial settings or something like that, so that it's clear that you're going to have a couple of different types of places where this could be found. And outside of that, there's not really going to be a use or indication for treating potential hydrogen sulfide toxicity.
With this, the tox kind of falls in line with the hazmat teams in the out in the field. We have the ability to meter specifically for that gas. Is it plausible just to maybe add that hydrogen sulfide has to be present at the scene where the patient is located? I mean, that's going to be our key indicator that, hey, this patient is poisoned by this. That would key me to call the poison control center and say, hey, I have it present in the atmosphere. They were down.
So, but it depends on the device you're using to meter, right? Like it depends on which one you're using and what your suspicion is, or you would always be checking for this.
No, hydrogen sulfide's we call it 5-gas meter. It's present. It's almost always looked after because it is so prevalent. Just in basic homes and businesses, it's often what we get called for. Hey, I smell the rotten egg odor, and then we go in and it's one of the gases that we're most commonly checking and seeing and finding when people think they have a gas leak inside their home or a gas leak inside their business. It's also one of the ones we are looking for. It's present. It's not like we have to change gears and say, okay, now let's check for that gas.
Right, but hydrogen sulfide toxicity wouldn't be what you would normally be finding in a regular gas leak.
Not a natural gas. I mean, not a propane leak or anything like that, right? It's
You're looking in like
gas is what it boils down to.
Yeah, like manhole covers. Yeah, people. We have our TRT teams who also have the same meters. Like, so if they're going to do confined space rescues, they are actually, I think they're mandated at OSHA to meter previous to going into their confined space and meter through the duration. So I was just throwing out there that we have the ability to specifically focus on that gas or find that gas.
Okay. Well, I do like then Dr. O'Connor's suggestion to say that it is rarely indicated except in cases of confirmed presence.
Well, it's actually rarely indicated even in confirmed cases of hydrogen sulfide.
Right. I'm trying to capture like
Yeah.
sort of how rarely indicated it is.
Yeah, I mean, I guess the thing that I would suggest is there's two adjustments I would recommend in this. Under absolute contraindications, I would make the first bullet point hypotension and hypoxia, and or hypoxia, or just do, you know, hypotension, bullet point, next bullet point, hypoxia, next bullet point, use with caution for significant carbon monoxide poisoning or smoke inhalation. And then, so that's, you know, like, so those would be my contraindications for this. And then up in the indications, I would have just clarified, let's see how, yeah, I'm trying to think about the right wording as well. May be considered on rare occasions in the use of hydrogen hydrogen sulfide poisoning. Something that just puts a big qualifier on there that because those patients typically are hypoxic and hypotensive, it's usually dangerous to give to those patients outside of getting them away from the source and putting oxygen on them. But if we want to make sure that they know that this is, you know, for their training and for their education, that may be a consideration.
Since this is just the drug profile, maybe we just use your simplified verbiage of saying it's rarely indicated. Just since this is the drug profile and not really part of the order.
Okay. Yeah. Yeah. Rarely considered for use in the treatment of hydrogen sulfide poisoning. Maybe something like that.
Okay.
Or
I think this definitely points out we've got some opportunities to kind of, as Marco was mentioning, clean up some of our treatment guidelines, because this is really just talking about teaching about the drug, but our actual the treatment guideline, we can probably do some cleanup to kind of really clarify when they should even be considering this, if at all.
Yeah, I agree.
Maybe we do add to it poison control with it or some type of higher level.
Yeah, I think that's probably in the actual teaching.
In the guideline.
Yeah.
Yeah, in the guideline.
Yeah, exactly. Okay. And then you can erase what's highlighted down there, Shelley. Yeah.
All right.
Perfect. Okay. Oh, and then you're rarely considered. And then you have, but not always indicated. I think we can delete that.
All right. Does that look like reflection of what years are opening? Okay.
That sounds good.
Moving on.
No questions for that. Yeah, we can go to the next one.
Sodium thiosulfate.
yeah, the recommendation I'd make in this one is add chromates to the list of other things it can be used for. As far as can be used following ingestion of bromates, chlorates, chromates, and iodine.
For the section guidelines containing.
No, indications right after chlorates.
Bromates, chlorates.
Okay. Okay. And then repeat, please.
So after chlorates, comma, chromates. Yep.
CHROMATE.
Us.
Without the H.
I'm sorry, you said no H on chromate.
Do you need an S? Is it chromates?
Yes.
Or is it chrom? Yeah.
And no absolute contraindications, Dr. O'Connor, for this one?
Not that I can think of. Yeah, none that I could come up with.
Okay.
Is there no H in it?
And what chromates? Yeah,
Yeah.
CHROMATES.
Yeah.
Sorry.
There you go. Okay. Oh, it wasn't looking right. Okay.
Yeah, but otherwise I didn't see anything.
Okay.
All right, moving to the next. Methylene blue.
Yeah, I mean, I think looks good as well. The only thing, or an absolute contraindication in addition to G6PD deficiency would be active hemolysis, which of course they probably won't know in the field because they won't have the ability to do those lab tests. But
For a second bullet.
I'm sorry.
Did you want that as a second bullet?
I mean, you could say acute hemolysis is an absolute contraindication. I think that's relatively important that they recognize. I just don't know that in the field they would have the ability to
Yeah.
determine that, unless the patient says, "I have a
That's
known
their-
history of hemolytic anemia." If the patients, patients who have hemolytic anemia know that, but so you could say acute hemolysis or history of hemolytic anemia, perhaps. And yeah, I think it's really nice that second bullet point under precautions and side effects. It's really important to highlight and educate them that their pulse oximetry is going to fall to 85% and hang there after methylene blue. So they need to just stop. They don't even have to record their pulse ox after that because it's not going to be any good. So.
And that's one we still need a guideline for, right? We still don't have we have the drug, but no.
Oh, is that right? You don't have a treatment guideline for it?
Not yet.
Okay.
Okay, I think we're good, Shelley.
All right, we'll move to the next one. Atropine and probably, I don't know how to pronounce that.
Is your auto injectors, do they have Valium in them too, or they just have the two? They just have the. Okay.
I think it's just like the duodote
Yeah.
type.
Okay.
Some people have, I would say some people carry the atropines for kids, but that's not common either. It's usually the duodote. And then usually atropine separate.
And Valium separate, yeah.
Yeah. I think we'd highlighted these times because we looked them up on Daily Med, I think.
Yeah, I'd have to independently look at I didn't look at the times that closely. Sorry.
Yeah, it might be something we could send to one of our like pharmacy residents or something to look up and
Still check it. Yeah.
double check times and stuff.
I have LexiComp. I can always. I mean, the problem is you're talking about two different drugs, right?
I think so. Yeah, that's why we weren't sure. But,
Do we need the IO route on an auto injector?
no, we didn't need that. And it's IM.
Correct, IV and IO.
Yeah. And just put in IM. Yeah, perfect. Thanks, Shelley. Are we done with this one?
What's the add organophosphate one? So is that just the organophosphate guideline then? Do we have?
Yeah.
Okay, so we just need to
Yeah.
hyperlink it.
Oh, is that just a hyperlink so it takes them to the other? Yeah, I didn't know what that asterisk was at the end. So
Yeah, we would just need the hyperlink, right?
Yeah.
Or do we have a guideline, Shelley, for this?
I thought,
There is a guideline.
I don't think,
yeah.
There is. Yeah, we just need the hyperlink.
oh, I missed that. I'm sorry.
Yeah. It'd be under what, acetylcholinesterase inhibitor poisoning, nerve agents, organophosphates, and carbamates.
I think the algorithm is actually going to need to reflect the ability to use an auto injector as well.
Not in there.
Yeah, the guideline has them separate. So that may be another one to bring up for, was it PMD then?
We have the drugs separated too in our tox box.
Mm-hmm.
Yeah, some people do, and so we'll keep them together. I think we just need to add the option for the auto injector, right?
Right.
Yeah.
Yeah, because because the regular units should have just regular atropine, even if they don't have the duodote, they just won't have a pralidoxine.
Right.
But a lot of them do have the duodote.
Mm-hmm.
So make a note. We'll need to, yeah.
So the reference I have Lexicomp, as far as, since we changed it from IO or IVIO to IM, that does change your kinetics a little bit. So it says time to peak in serum after IM administration is 35 minutes versus the 5 to 15 when you give it IV. Oh yeah, there.
We have 34.
Huh? Oh, yeah, I was looking at onset. Sorry. Yeah. Yeah, I was gonna say 16 minutes and 34 minutes are very precise, very specific. It must have pulled some sort of reference, right? So, but that's for pralidoxime. Obviously, atropine's a different drug. So, I haven't looked at those pharmacokinetics necessarily, but they're probably very similar. And those are in here just for general information, or
Pretty much.
okay, yeah, I think that's fine then. Yeah.
Move on. Propranol.
And then we got to change on the title for the first one. It's propranolol. There's an R missing. Just to, yeah. Okay.
Yeah, this is
Anything.
okay. So you guys carry this specifically for like myocardial sensitization following huffing, essentially, right? So, which is always a tough one because, but the medics are the ones who are going to know what the circumstances were. If it's an adolescent who's with a bunch of friends and they take off scattering and somebody went down. And so I would actually probably use the terminology huffing or some in parentheses, because it does say hydrocarbon inhalation, but and this one's tough because they typically are going to be in a ventricular dysrhythmia, that they're hypotensive. So if we say that the absolute contraindications include, those are accurate in a sense, but in the other sense, if you're coding from a hydrocarbon ingestion, the patient's likely going to be in a non-perfusing rhythm and hypotensive. But in the setting of huffing, you would consider giving this agent, I guess, is why this is here.
Call. So for indications, Shelley, we can put a parentheses after exposure and say huffing, or i.e. huffing or whatever.
Yeah. Is that the main, like, how often does this drug get used in the field?
That's about it.
Yeah.
That's about it. I mean, most of these are used pretty rarely. 'Cause, I mean, even though our tox teams tend to be our hazmat teams, like, most of these calls aren't hazmat calls, right? So like the general medic does not carry propranolol. So I would guess that most 911 huffing calls for cardiac arrest are a general medic, not a tox medic. So that's sort of the problem with some of these, is that these are specifics to the tox box, and normally the tox box is with the hazmat crew. So you might have a hazmat truck on a scene, but it's rare, right? So most of these 911 calls for stuff like this are going to be a general medic that doesn't carry propranolol. So it's rarely used.
Okay.
Yeah.
And quite frankly, in the setting of huffing and a ventricular dysrhythmia, you'd almost prefer to use esmolol, which I'm sure they're not stocking esmolol, but esmolol, because it's so rapid on, rapid off, given IV, is a better agent. So okay, yeah.
Well, what would be a recommendation then for the absolute contraindications then? In the setting of huffing, you're saying there aren't any contraindications?
Well, I think, the problem with huffing, right, is that they're going to be in shock. They're going to be hypotensive in a non-perfusing rhythm. And
maybe not sinus bradycardia, maybe just leave sinus bradycardia or heart block, because that'd be different. You're not thinking sensitization from huffing, you're thinking of something else then, right?
Yeah, I mean, these are absolute contraindications for using propranolol in the general context, I guess, right? Like, you're going to make somebody, these are all accurate contraindications, but you're going to make any of those patients worse by giving them propranolol. But in this isolated specific instance, you're talking about hydrocarbon-induced myocardial sensitization. And in that setting, despite these contraindications, you would give this drug. So
should we make it more specific to ventricular dysrhythmias? Would that be more accurate as an indication?
Yeah.
And then we can get rid of cardiogenic shock, because we're being very specific about.
Yeah, like I said, the crux is they have to understand the isolated. The reason that this is there is for that specific instance of hydrocarbon-induced dysrhythmias, and those are almost always ventricular dysrhythmias.
When we teach this, we teach give the propranolol and withhold the epi. If you're really treating a cardiac arrest and they're in VTAC from this, you'd give this instead of epi, essentially.
That's right. Yeah, the catecholamines make it worse, right? You get sensitized to the catecholamines, and catecholamines worsen it. But as long as I would just maybe make sure it's loud and clear that this is purely in the setting of huffing hydrocarbons or inhalational exposure to hydrocarbons, i.e. huffing and resultant dysrhythmias, ventricular dysrhythmias. Yeah.
Okay.
And we don't have this guideline yet either, do we? No. So we can tailor the guideline, I guess, specifically to, that instance. Right? Yeah. Are there any other hydrocarbon? I mean, would there be any other hydrocarbon exposures, Tanner, that you can think of that you guys would run on that we would know, and outside of like a huffing? And
I mean, I gotta imagine hydrocarbons would be decently common out in commercial, some sort of production or assembly. My hazmat brain's not turned on right now. I'm trying to think of a specific example, but yeah, this is not one that I'm even familiar with. So when it got brought up, this would be new, at least for, I think, most Valley agencies to, right? We don't have an algorithm for it. I don't think many people carry that drug.
Yeah, we do down here. Our regional hazmat team in the Southern Arizona region carries it for this indication,
Okay.
but I don't know that anyone's ever used it. So for this, I mean, they do get called on hydrocarbon calls, like where the hazmat team will clean up spills. You know, that's the most common carbon type call, but generally not for medical stuff. But
I mean, we do have a lot of fuel yards and things like that in the Valley. I don't think we've really had any. They're so regulated. We haven't really had any incidents. So
yeah.
All right, so we took out that one absolute contraindication.
Mm-hmm. Yeah. Yeah, because I think by definition, they'd probably be hemodynamically unstable if they're in a ventricular dysrhythmia for this specific thing. So I think Dr. O'Connor had a good point. Sort of.
You want me to add ventricular on the indication line?
Yeah. And then maybe put like IE huffing, like for example, huffing, just so that, you know, it's not exclusively huffing, but we'll remind them that would be one of the more common causes.
how does this drug work? When we're talking about like smoke inhalation victims, we a lot of times, we're relying upon the effects of cyanide and carbon monoxide poisoning. Is this a drug? I heard you guys talking about using this in place of epi in your hydrocarbon type codes. But the products of combustion are unlimited, right? And we're heavily plastic based in today's homes. Is that another where I guess I'm seeing something that we could be using, or
no, it's generally not from combustion products like byproducts. This is from huffing hydrocarbons primarily.
Okay.
So you're breathing in the hydrocarbon prior to combustion.
Okay.
And this is sensitizing the myocardium to catecholamines. So even your endogenous catecholamines can throw you into a ventricular dysrhythmia because your heart becomes so sensitized. And so you want to decrease the sensitivity of the myocardium to your endogenous catecholamines, and you want to avoid giving them more catecholamines.
Okay.
Is the sort of basis.
So basically, the only way this is going to come to play or become relevant is in the setting of somebody misusing and or abusing hydrocarbons from a canned source, in an intentional attempt to get high. So whether they're huffing spray paint or huffing, yeah.
So just being around the product, like the dose limit, you would have to be purposely trying almost to get to use it. Okay.
I mean, there's on it. I mean, and I don't think you guys would get called on it either. Like, I don't know how probably not that often, like kids that'll unintentionally drink you have ingestions.
Yeah, ingestions
but
are
that's not gonna. That
and this isn't for ingestions of hydrocarbons, right? So
this is just going to be respiratory. Okay.
Yeah, this is inhalational exposure.
Inhalational only.
Well, thank you.
Yeah, I'm finding it anywhere else. Lighter fluid.
Yeah, not really.
No, those are actually preferred, right? If you drink a hydrocarbon, and a simple hydrocarbons will go straight through you. You might get a little diarrhea, and if it gets in your skin, it'll cause some defatting necrosis. But those are easy, right? There's not going to be any myocardial sensitization occurring necessarily from those. So.
Just looking at that lighter fluid. I mean, I'm just trying to look to petroleum distillates and polishes, lamps, oils, lighter fluid. The fluorinated ones for used for refrigeration, some insecticides, the
If you huff
halogenated.
those, the fluorinated hydrocarbons are common, right? So a lot of people huff Freon.
Freon. So if
Yeah.
they'll do Freon.
That's exact. So if you find somebody near a air conditioning unit, and that's one way that they would actually access those units and then huff that Freon. They could go down, and if they're in a ventricular dysrhythmia, this would be a place to use that. So.
And then turpentine and pine oil. So I guess if they're
Those
using
are
an aerosolized propellant of those,
Yeah. But again, another call where the primary 911 call would be for.
it's probably going to be a regular EMS. Yeah, it's probably not going to be a.
But it's sort of the rub in some of these, but.
Yeah.
Yeah. Okay, cool. Thanks, Dr. O'Connor. What's our next one, Shelley?
The last one is Hazardous.
Yeah, this is the combination product of the first two that we reviewed.
So maybe just make the verbiage the same, add the chromates and our rarely indicated verbiage for hydrogen sulfide. I think that's what we did, was just copy the verbiage from the other two.
Mhm.
And then after chlorates, Shelley, you can add chromates again, monochromates.
And that's tough because you would definitely want them to know that that's really just only the sodium thiosulfate for that indication, right?
Oh,
Like
yeah, you're
you
right.
don't give sodium nitrite. Like, so under indications, you might want to
You're
label.
right. Oh, you're right. So they wouldn't use this though, right? At all for those.
Well, I guess it comes as, I'm assuming it's got 2 vials in it, right? Like they open it up and it's got the sodium, or it's not pre-mixed together, is it? I better
No,
go
it's from what I've seen, it's 2 separate vials just in the same box, since the label is the nithiodate.
Oh,
Yeah.
okay. So we would say maybe, but combined together, they would not be indicated for them. I'm trying to figure out the best way to put this.
Yeah, really, nithiodate is technically only used for cyanide poisoning, right? I mean,
I think you're right.
You wouldn't want to confuse them.
Yeah, I think you're right. I think we probably should just delete those other indications. The other two. Because they could use part of the nithiodate kit
Right.
if they wanted.
Yeah, like
They
if you
are-
had a
yeah.
chlorate and bromate exposure, and you only had the nithiodate kit, you could break it apart, they would need to know that they're using just the sodium thiosulfate and not administering the sodium nitrite.
So maybe we put another bullet below saying the sodium nitrite can be used alone.
Probably the opposite, right? Say sodium thiosulfate can be used.
Yeah, sodium
Used
thiosulfate
alone.
can be used alone, and then say C sodium thiosulfate card or drug profile.
Yeah.
Can I suggest the wording be more along the lines of this dual product can be scavenged for the sodium thiosulfate component, and then the language that you said, Amber, of see that guideline or that profile for further details.
Okay. Sounds good.
All right, refresh me. What do you
Say it
want
again.
on the other? Yeah. There you go.
One more time, Franco.
So I see your cursor there. So you can say instead of separated, say scavenge, just to kind of impart the idea that we're breaking up the kit. Let's see.
Vials can be separated, or I mean, because they're two separate vials
Yeah.
that you have
Yeah,
to
that's what
draw
I'm
up
saying.
separately.
So address it as the kit. The kit, you're breaking up the kit, not the vials necessarily, but and so you can say it can be scavenged for the sodium thiosulfate ingredient.
Or do you want to just, this is under indications, so you just want to say, see additional drug profiles for specific indications of the
Mm-hmm.
each component or something. I mean, because really, so the niothiodate kit you're going to use in the setting of what you suspect is acute cyanide toxicity.
Mm-hmm.
And then, but because it's got two active ingredients in it, you're saying there may be other indications, see separate, drug profiles for sodium nitrite and sodium thiosulfate. And
Separate.
then separate, yeah.
Okay.
Yeah, that's a good idea.
And then at the bottom, you could probably put the, can be, the separate drugs can be used independently if other indications are present, if appropriate indications are met or what have you. Presumably, do they all have all of these things? They would have this kit, and then they would also have sodium thiosulfate and sodium nitrite separately, or this might be the only stock of such berries.
It could be either one, just because they're all optional. So they could, just depends on operationally what they feel like buying.
Yeah.
Okay.
Okay.
Something like this. See drug profiles for separate indications of sodium nitrite and sodium thiosulfate.
Yeah, I think that'd be
Mhm.
the safest, right?
I think from the user side of that, I like that wording, and I would love hyperlinks for each, right where we're at in indications, sodium thiosulfate, it goes to the other drug profile. And
Well, now you're just getting greedy, Tammy.
hey, we need a firefighter proof.
Yeah, I like it.
Just kidding. Yeah. Okay.
Whenever you have, kind of murky waters, you don't want to repeat it multiple times if you don't have to, right? You just want to refer to the other murky issue.
Exactly.
All right.
I think absolute contraindications for this one. You wanted hypoxia listed? Like the same contraindications, right? As we had it before, the 3 different bullets.
Well, again, you might want to, because you can give sodium thiosulfate to a hypoxic and or hypotensive patient all day long, but you can't give sodium nitrite to it. So
Does the kit?
Yeah. So you may want to. Yeah, I didn't think about that.
Yeah, I think as the kit, we want to include all 3, right?
Well, what you want to do is let them know that here again, if the patient is hypotensive or hypoxic, they should administer the sodium thiosulfate, perhaps only, right? So you give sodium thiosulfate in the setting of a patient who's hypotensive and hypoxic, and withhold sodium nitrite to avoid, making the patient more unstable.
So maybe parentheses after hypotension saying sodium nitrite only. And then
Sodium thiosulfate. As far as that's going to get correct.
Yeah.
Yeah, we're going to have to really make that.
Or sodium nitrite contraindicated.
Yeah, I would say
clear.
point.
Portion, sodium nitrite portion contraindicated.
Yeah, I would like,
Clear which one is contraindicated, right?
yeah, I mean, really, it's the sodium nitrite that's the problem, right? And sodium thiosulfate, there really isn't a contraindication.
Would it make more sense to say may use sodium thiosulfate after the in there, or would it make more sense to say
I think so. I think what you want to do is find a way to wherever we want to put it, you want to highlight that the sodium thiosulfate component can be used safely, even in patients who are hypotensive and hypoxic, but the sodium nitrite cannot be. So we need to probably spell that out
Sodium thiosulfate safe to give
in patients
with hypotension or
and hypotensive or hypoxic patients, but then say sodium nitrite is contraindicated in those patients. So,
are we saying this is in the presence of carbon monoxide, smoke inhalation?
any hypoxia, hypotension, yeah, and carbon monoxide would also be another one you wouldn't necessarily want to give.
well, the problem is carbon monoxide and cyanide, they go hand in hand, right? That's the fear. And so I presume the reason we're saying use with caution, so this is absolute contraindications, and yet we're saying use with caution in significant carbon monoxide poisoning and smoke inhalation, which is also confusing. But we would have to go back and fix all the other ones too. But because they're saying, oh, well, if carbon monoxide poisoning and smoke inhalation is contraindicated, then I shouldn't be giving the sodium thiosulfate or the sodium nitrite is what they're going to take away from this. And is that really an absolute contraindication? What we're trying to say is, you know, patients who, I presume we're saying we're listing those two scenarios out because those are the situations where we're going to find hypoxic patients from other sources. Is that accurate? Is that the reason that's there?
Which part? That precautions one?
Yeah. So under absolute contraindications, it says use with caution for significant carbon monoxide poisoning or smoke inhalation.
Yeah, I think that's kind of worded weird. I mean, I think what we need is if you think they have carbon monoxide poisoning / smoke inhalation, you know, any kind of other simple asphyxiant, you probably don't want to use this.
Yeah, I think for the firefighting side, if you're thinking, hey, we have a cyanide poisoning, but you're forgetting that they also have a carbon monoxide poisoning as well, we don't want to drop those drugs, right? Or that drug.
Yeah,
You can safely drop the sodium thiosulfate.
Just
you
not
can't
here. Sodium
just drop the nitrite.
right. And I think that yeah, I think we just have to make sure we say, and I think the use with caution is confusing. Like we don't want them, we just want them to think about the possible presence of carbon monoxide and smoke inhalation. But really we're saying if you think they have it, don't give the sodium nitrite. If you think they have carbon monoxide poisoning. Right? I mean, the intent is,
it's only if they're hypoxic or hypotensive, right? So that's real. For me, the absolute contraindications for giving sodium nitrite are that they're hypoxic or they're hypotensive. So those are the absolute contraindications.
okay.
When you put a use with caution under an absolute contraindication, it becomes confusing to me.
Right. Well, that's what I'm wondering. Should it be a caution down below, or should it be
move it down?
Yeah.
Should it be an absolute contraindication?
Yeah, I would say, you know, absolute contraindications. I would say bullet point sodium nitrite, hypotension and hypoxia. Then I would probably, under your precaution and side effects, if you want to add that part about use with caution in patients with significant carbon monoxide or poisoning or smoke inhalation, you can put that in there. You just may want to clarify why you're, you know, using it with caution. So. Because, I mean, quite frankly, there are going to be patients with smoke inhalation and carbon monoxide poisoning that you may be, isolated carbon monoxide poisoning, probably not, but the fact of the matter is in a lot of house fires, right, you're getting exposed to multiple gases.
Mhm.
And if they're acidotic and or seizing or hypotensive, you would want to give them the antidote for cyanide poisoning, but you wouldn't want to give them sodium nitrite. You would want to use hydroxycobalamin and
Yeah.
or sodium thiosulfate, either one.
So we can delete those top 2 bullets under precautions though, right? And just keep our carbon monoxide one. Because we put hypotension and hypoxia in.
Well, the problem is you have precautions and side effects.
Yeah.
So now you've got.
Oh, I see what you're saying. Never mind. I'm misreading that. You're right. Yeah. That's a side effect, not a precaution. Okay.
Yeah.
Yeah. I was misreading that. I wonder if other people would misread that. Maybe we say may cause hypoxia, may cause hypotension.
Well,
Because
what you
then-
might want to do is consider, and I know this is a lot of work, but you may want to consider breaking apart precautions and side effects because they're very different, right? So,
Yeah.
and you don't want people to be, do you want to confuse them? Because you have your absolute contraindications and then you have your precautions. And to me, those two things go together more than side effects go with those two things, right? So
Yeah.
if I have my absolute contraindication, which means nobody should give this no matter what. And then you have your precautions, which is, hey, you know, in this scenario, it's the, you know, carbon monoxide poisoning or smoke inhalation. And then you have, what can you expect the side effects of these drugs to be, which is totally separate in my mind.
Yeah. Yeah. Maybe we'll have to bring that up when we reformat or when we go through the next review of all the drug profiles and consider breaking them up on our next reiteration. Because I think it'd be hard to do it for this 4 if the rest are not, but I see your
Right.
point and see that we probably should break those apart.
Yeah.
Which isn't necessarily like, I don't know, Shelley, I don't know if that's something we would have to take back to the committee because we're not changing it, we're just reformatting it, right?
We'd have to address each drug profile.
Even if
See
you're
where
not
we wanna-
changing anything though, you're just literally taking the precautions and side effects and separating them on the drug profile. You're not adding or removing anything.
Oh, like for these 6?
Yeah,
Or
like
all.
yeah, if you took all the drug profiles and separated out precautions and side effects and just reformatted it so that they were listed under different headings, would you actually have to go to committee for that? I can't imagine we would, right?
I can't imagine.
I don't know. That's something we could ask Gail.
I'm back.
Oh,
Although Shelley's who I go to for all of the statutory keep us out of trouble rules. So
yeah, exactly.
but
Did you hear
for these ones, I would
It's good to
absolutely
get-
say build these in the format that we want that makes sense because we always have the opportunity down the road to update the others.
Okay.
So if there's an opportunity with these 6 and they have a slightly different format from the other drug profiles, I'm okay with that. Rather than us putting them in a format now, first time around that we don't love, and then 6 months from us having to do this work again.
Okay. Yeah, I think we were trying to save page space, but you know, I think that Dr. O'Connor's point is good and that they are really very different things. So
I'm trying to add a new row and it's not doing it. God darn it.
it's not letting you. Shelley, I don't mind adding those either if you want me to change those ones. Or I can tell you which things are precautions and which things are side effects.
Okay, let's do that.
I can make a list. I mean, they might be list, but
So may cause hypoxia as a precaution.
no side effect.
Okay.
And the side effect is also the second bullet. And then the third bullet is a precaution.
Okay.
And then maybe let's briefly scroll through the other ones and see if we need to break any of those up as well.
Okay. Get rid of highlight. titer. Propranol. Do we want to change the header to one or the other?
Yeah, this one's well,
Side effect.
yeah,
Yeah, that now I know, right? Like, so now you see, because you don't want to, you want to use it in caution in patients with CHF and heart block,
right.
but it also causes, can precipitate those things. So,
Right. Exactly. So this one's kind of both in a way.
But and this is where this kind of, normally you wouldn't give this drug in those settings, but in this one isolated scenario, this is where you would give the drug. So despite having those contraindications and or precautions present. So
Yeah. So in the setting of huffing and hydrocarbon toxicity, we wouldn't consider CHF or hypotension a contraindication or a precaution, right? In that setting.
right. So really, honestly, if we're saying propranolol and specifically for hydrocarbon inhalation, and we would say the absolute contraindications would be a known hypersensitivity to propranolol, hydrochloride. And then really precautions would be, the cardiogenic shock and but again, well, you wouldn't be giving it to somebody for a first degree block or bradycardia, right? You're giving it for ventricular dysrhythmias.
Yeah. And I've heard some different things about whether or not to treat PVCs. I mean, if I got a phone call about it, I would say not to treat PVCs. I would say just bring them into the hospital in terms of giving propranolol in the field. But I don't know because we're kind of talking about VTAC, like real ventricular dysrhythmias, but some people do get just a lot of PVCs.
Yeah, we wouldn't want this being used for that indication. I mean, this is truly, unless I'm missing something, propranolol is in the box because of, myocardial sensitization from hydrocarbons, and that's going to be polymorphic VTAC.
Right.
It could be torsades. It could be,
Yeah. Okay.
So our indication would be is good, but then our absolute contraindications we're kind of going against because they're going to be in shock or hypotensive, and we're going to give this drug anyway. So
right. You're right. So our absolute for this, and I'm just typing this out for Shelley's benefit, but so our absolute contraindications would be known hypersensitivity.
And this, yeah, I think you may want to consider putting somewhere on here that this is for, that indication.
Would you want to specify an indication just specifically instead of just ventricular dysrhythmia, something like torsades or VT? I mean, do we want to make it a little more specific so they're not thinking PVCs?
Yeah. Well, ventricular dysrhythmia is encompass both, right?
Right. I'm just wondering if I don't know. I worry if somebody looks and goes ventricular dysrhythmia, if you are throwing a bunch of PVCs, but you're not there yet. Like I said, that would be the question that they may say that, yeah, you've had that, but.
If they're awake talking to them, they shouldn't be giving this, right? So you're right. Instead of symptomatic, you could just say, ventricular dysrhythmias.
Such as VTAC or torsades.
Yeah.
Yeah.
I'm just wondering if you need to clue them in a little bit on what we're really looking at with ventricular dysrhythmias versus, something a little more not benign, but that wouldn't be indicated like frequent PVCs.
Yeah. I mean, I think the difficulty with these specific protocols is that these are very selected indications and scenarios that we're using these versus our other ones where we have more of a broad set of indications. I don't know what you think, Gail, but
Yeah, I mean, I would specify, I like specifying,
Mhm.
torsades or VT because there are some agencies that treat PVCs, whereas I think most of us that work clinically don't treat PVCs. And so I think specifying that, just because this is kind of going, once this gets published, it's for all comers with different medical directors. And so I think having that specification of this is what the true indication is for is useful.
I mean, I would maybe change it to ventricular dysrhythmias caused by hydrocarbon inhalation exposure, and then parentheses, i.e. huffing.
Yeah.
And that's your indication for this drug. And then, the absolute contraindication for giving it in this basically code situation is if you have a known hypersensitivity, and then your precautions would typically be all those things listed that we have here, except for the fact that we give them in spite of those precautions due to the unique pathophysiology associated with myocardial sensitization from hydrocarbons. So that's if we're going to break apart all of them and have absolute contraindications, precautions, and then side effects as separate things, you could just say, I think.
I mean, in this setting, there really aren't any. Right? I mean, absolute, other than hypersensitivity.
Right, because that's right, because it's a very specific, very narrow indication for which they're using this drug.
Yeah, and they're in attack, right? So,
yeah.
And then precautions, I think, I don't know what you would say, Dr. O'Connor. I would almost consider saying, caution against co-administration of epinephrine, or, and then also whatever other precautions that we have. I don't know if there are any other precautions.
Yeah, I mean, I think you might want to alert them that if you give this drug to an asthmatic, you can precipitate bronchospasm.
Yeah.
Now, most asthmatics don't get into huffing, but it usually precipitates bronchospasm. But
yeah. So absolutes known hypersensitivity, precautions is going to be may precipitate bronchospasm
in asthmatics. And then it can exacerbate, it can cause and or exacerbate bradycardia, heart blocks, hypotension, and CHF. Certainly that is true, right? It can do those things.
Yeah. So may cause or exacerbate bradycardia, heart block,
hypotension, and CHF. I mean, all those things are true.
Okay. I think it's fine to put in the precautions.
You think what?
I think it's okay to put in the precautions.
Mm-hmm.
And then precaution against co-administration with epinephrine if in cardiac arrest.
Do you want to stipulate for hydrocarbon inhalation or huffing, or cardiac arrest following huffing, or cardiac following? Avoid co-administration of the epinephrine.
Something like that. Against co-administration of epinephrine if in cardiac arrest following huffing.
Yeah.
I don't think people often realize that, and they start giving epi because it's reflexive in cardiac arrest.
Right. No, if you follow ACLS, you're going to be given epi, and in this particular scenario, that could be making it worse, right? So.
Yeah. And then side effects now. So precautions are the first. Oh, no, wait. Oh yeah, delete that top bullet, shall we?
Gravity. Oh, computers.
Showing you, Shelley.
The first two bullets are side effects, and then we have a bullet.
So the precautions are, maybe that's a side effect. May precipitate bronchospasm. That's a side effect. Sorry.
Okay.
And yet the precaution is using it in asthmatics.
Right,
So-
I guess. Yeah.
Yeah, so it's funny how when you take two different drugs, you see how precautions and side effects can be lumped together versus when they can be more confusing. So,
Yeah, and then the precaution is the caution against co-administration part. And then that may cause or exacerbate, that's also a side effect, where it says may cause or exacerbate. Yeah. And then the precaution is just the caution against co-administration with,
Okay.
exactly.
Getting there.
Yeah, we are almost there. And then you can delete the top, and then the top bullet can go.
Okay.
Yeah, because we organize that. Perfect. Okay. Okay. All right. And then you make it with one more, Shelley. We'll look at these ones.
Well, I'm sorry.
The next one up. The next number 4. Just
We're gonna
with
leave for all of them.
this one's a precaution, right?
which one?
The pralidoxime is not
Wait a
effective
minute, just
treatment.
Yeah.
And then I don't know what we have at the bottom. Pralidoxime is not indicated as an antidote for intoxication by pesticides of the carbamate class, since it may increase the toxicity of, carbaryls. Okay. I couldn't remember what we wrote there.
Yeah, you can make that 2 separate bullets, or you can,
Mm-hmm.
or you could just say it's not effective in the treatment of poisoning due to, and list all of those things, really, right? I mean, or it's fine to keep separate too. It's just we're basically telling them all the things that they shouldn't use pralidoxime for, and it's only organophosphates that undergo aging.
Mm-hmm. Can pralidoxime be given IV or IO?
Can definitely be given IV. The question becomes IOs. I don't know my IO stuff right off the top of my head, but I'd have to look that up.
Pretty much anything can go into an IO that can go into an IV for the most part. Do you want to add IV, IO to the administration, Shelley?
Sure.
Yeah, perfect. Yeah, okay. Okay, maybe up one, and then we can get rid of the word, because this one's no longer side effects, right? It's just precautions.
That's right.
And then I think that's it for that one. So maybe go up to 3, Shelley.
All right.
And then this one, chest pain, vomiting. So these are side effects, not precautions, I guess.
Right.
Okay. And then number 2. Side effects again. Well, hypotension would also be well, that's listed in our.
Sodium thiosulfate. I don't
Hypotension, right?
think that causes. I mean, only if you are in renal failure and you get sodium thiosulfate, and you get. I don't know that hypotension is a side effect.
I think it might have been carried over from the sodium nitrite one.
Yeah. Yeah.
It might have got copied over. This one has nausea, vomiting, muscle cramps. Hallucinations.
It does list hypotension as one, but I've never known it to cause it. Yeah, they do list it as an adverse effect, but it doesn't define its prevalence or how often it occurs. And historically, obviously, it used to be given, they were given together. So I don't know.
I mean, if it's not something you would particularly worry about in the administration of it, then I'd leave it off.
Yeah, I would. Right. This is the one drug you want them giving in a hypotensive patient as opposed to the sodium nitrite.
Yeah.
Do you want me to get rid of the word precaution?
Yeah.
Yeah, unless they have a sulfite hypersensitivity. I don't think there is no real contraindication or no absolute contraindication.
Okay. And then we can look at our top one again, shall we?
All right.
This one again is side effects, right?
Yeah, it'll cause all those things as side effects. And then I think we have our precaution up with our absolute contraindication, right? So.
Yeah. Yeah. Oh, you're good, Shelley. You don't need to add that, right?
Oh,
no, you're right. You're right. You're right.
You're going to break them apart into 2 sections. So
Sure.
Then you would create a precautions and say use with caution for significant. Yeah.
Yeah.
And then.
That's great.
Yeah.
Okay. 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 That looks pretty good. So look at our. Is there anything else on our agenda, Shelley, after these for today?
no.
Okay. We didn't have the TTTGs on here for that, right?
I'll be adding that to the PMD agenda for November.
Got it. Okay. Perfect.
If we, I guess we could get some draft ones ready for the meeting. As far as the work group, we're just working on these.
Yeah. Do you want me to
Shelley?
send you ours, Shelley, from, or go ahead, Gail.
I was just going to say, could we work on them and then just propose it to PMD for review? And if PMD wants to then form a subgroup to further work on it, we could.
Yeah, because they're obviously ones that we're lacking.
Yeah, because we kind of did that with the VAD one when we split it into total artificial hearts. We kind of identified a gap. So I feel as
Yeah.
if it's a reasonable thing. It still would go to the actual committee for review, so it would still go to PMD and MBC. But otherwise, we'd have to wait for March would need to be the next PMD meeting for it to be approved if we got like approval to open a work group. So we'd be pushing this off like a good 7 months.
Right. Yeah, we should probably draft something up.
I think as long as the committees have an opportunity to say, yes, we approve, or no, we want to reconvene a work group, I think that should be good enough to get public comment in.
Right. Yeah. Great. Well, thanks everybody.
Thank you.
These
Yes,
on the
thank you.
agenda, PMG in November.
Perfect. And Shelley and Gail, send you guys what I have for the toxmetic guidelines we have down here, or maybe Tanner has something they're using. We use Frank's, but
So I think could we potentially have one more work group? Maybe look at what we have and get them into the TTTG format for the missing one, and then just have another work group to review it before
Yeah.
November's meeting.
yeah. Do you want me to do that, Gail? I could put what we have currently, and then maybe I can send it to Tanner and see if he has any input or something.
Yeah, if you're able to, that'd be awesome.
Yeah, I can do that. I'll just take I think I have a version of it that's. Do you have a template, Shelley, that you could send me just in case I don't have a PowerPoint editable
Sure.
one? Then I can put those in there and maybe I'll send them, because I know what we do down here, and then I can send them to Tanner because they'll have an idea up in the Phoenix area if they do something different.
Yeah, we can get draft for consideration for the November meeting worked up.
Okay, cool. Yeah, I will work on those and send them to you ASAP.
All right. Great.
Thank you.
Thank you.
Cool.
Thanks.
Stop recording.